Hi everyone, welcome back to Yang Tube.
Alright, this is our second session on the musculoskeletal system. Last time, we covered the overview of bone. This time, we're moving into the composition of the skeleton, and we're going to focus on the bones that fracture most easily. Our body has 206 bones, but obviously, we can't study all of them, right? So, which ones should we focus on? We need to study and memorize the ones that fracture most often, because that's what helps you work more confidently when you're writing or interpreting medical records. Let's get started with our second session. Alright, we move into the second big section, the composition of the skeleton. Let's start with a number you should memorize. An adult has 206 bones. But here's an interesting question. Why does the number of bones actually decrease as we grow from childhood into adulthood? It's not that bones disappear. It's that separate bones fuse together into one. Two examples. First, the hip bone. In a child, it's three separate bones, the ilium, the ischium, and the pubis. But as we grow, they fuse together at the acetabulum into a single hip bone. Second, the vertebral column. We're born with 5 sacral vertebrae and 4 coccygeal vertebrae. The 5 sacral vertebrae fuse into one sacrum, importantly keeping their neural foramina, the openings that let nerves pass through, and the 4 coccygeal vertebrae fuse into a single coccyx. So remember, for the whole skeleton, you'll need to memorize every bone name. We have a separate video for that. But for bones by region, just focus on the major, commonly tested bones. Let's turn to the bones of the head, the cranial bones. There are 23 bones total, but rather than memorizing all of them today, I want you to focus on 4 sites, because these are the classic facial injury sites you'll see constantly in clinical practice. The nasal bone, the orbit, especially the orbital floor, prone to what's called a blowout fracture, the zygomatic bone or cheekbone, and the mandible, the lower jaw. On the next slide, we'll go through exactly why each of these 4 sites fractures so easily, using the example of getting hit by a soccer ball. So why do these 4 spots break so easily? Let's go through the soccer ball scenario one by one. First, the nasal bone. This is actually the most common facial fracture. Why? Because the nose is the most projecting part of the face, so it takes the direct impact first. Second, the orbital blowout fracture. When something too small to hit the entire orbit, like a ball or a fist, strikes the eye, the force compresses the eyeball, and that pressure has to go somewhere. It gets transmitted to the thinnest walls of the orbit, the orbital floor, made up of the maxilla, zygomatic bone, and palatine bone, and the medial wall, made of the ethmoid bone. This can cause diplopia, or double vision, and ophthalmos, where the eye sinks backward, and numbness in the cheek. Third, the zygomatic bone, or cheekbone. This happens from a direct blow to the cheek, and it often fractures along its sutures with the frontal bone, the maxilla, and the temporal bone because of that 3-point pattern. We call this a tripod fracture. Fourth, the mandible or lower jaw. This comes from a direct blow to the jaw, most commonly at the mandibular angle or the condyle, and it can cause malocclusion, the teeth not lining up properly, and limited mouth opening. And here's an important nursing point. If you suspect an orbital fracture, instruct the patient not to blow their nose. Why? Because blowing the nose can force air through the fracture site into the orbit, and that will actually worsen the swelling. Moving on, let's look at the spinal column, also called the vertebral column. First, the names and numbers of the vertebrae from top to bottom. Cervical vertebrae, 7. Thoracic vertebrae, 12. Lumbar vertebrae, 5. Then the sacrum, a single fused bone, and finally the coccyx, also a single fused bone. A tip for remembering the numbers. Think of meal times, 7 a.m., 12, noon, 5 p.m., cervical 7, thoracic 12, lumbar 5. That's a classic trick, and I'd recommend using it. Among the 7 cervical vertebrae, the first and second have very special shapes. The first cervical vertebra is the atlas, in Korean arepa, the ring bone. Just like Atlas in Greek mythology held up the sky, this bone holds up the skull. It's essentially just a bony ring, without even a vertebral body. The second cervical vertebra is the axis symphyr, the pivot bone. The axis has an upward projection called the odontoid process, or dens, that fits into the ring of the atlas, creating a pivot joint. This is exactly the mechanism that lets you rotate your head side to say no. So remember, Atlas supports the head, axis provides the axis of rotation. So we've looked at the vertebrae themselves. Now, let's talk about what sits between them, the intervertebral disc. Between each pair of vertebral bodies, there's a disc, and it has three main jobs. First, shock absorption. It acts like a cushion, absorbing the impact that travels up the spine every time we walk, run, or jump. Second, mobility. Without discs, the spine would just be a rigid column of bone. The discs are what let us bend forward, lean back, and twist. Third, it's a space keeper. It maintains the gap between the vertebrae, and that gap is exactly where the spinal nerves exit, through the intervertebral foramen. So the disc is what protects those nerves. Now look at the structure. On the outside is the annulus fibrosus, the tough fibrous ring, and on the inside is the nucleus pulposus, the soft gel-like core. When the annulus fibrosus tears and that nucleus pulposus pushes out backward, it presses on the nerve root, and that's what we call a herniated disc, or H&P. This is why patients come in with lower back pain radiating down the leg. Keep this structure in mind. The fibrous ring on the outside, the soft core on the inside. That's the key to understanding disc herniation. Next is the thoracic cage, or rib cage. Remember this number, 12 pairs of ribs, or costae. Toward the front, each rib connects through a strip of cartilage called costal cartilage, and at the center of the chest, connecting the ribs, is the sternum, or breastbone. What's the function of this bony cage? First, protection. It shields the two organs most essential to survival, the lungs and the heart. Second, respiration. The intercostal muscles between the ribs are one of the main muscles of breathing. When they contract, they lift and expand the rib cage, so air can be drawn into the lungs. Now, let's take a look at the bones of the arm. The bones of the arm can be divided into the shoulder girdle and the bones of the upper limb. The shoulder girdle includes the clavicle and the scapula. These are the bones where the shoulder muscles and ligaments attach, allowing for stable rotational movement of the shoulder. Next, the bones of the upper limb. There's the humerus, the long bone between the shoulder and the elbow, and then from the elbow down to the wrist, the radius and ulna. The radius and ulna help the wrist perform stable rotational movements. And then at the wrist, there are the 16 carpal bones. On the back of the hand, the metacarpal bones, and the finger bones, the phalanges. So among all these bones, which ones fracture most easily? Some of you may have injured one of these at some point yourself, right? Let's find out on the next slide. Alright, let's take a closer look at the shoulder joint. The shoulder joint is formed between the glenoid cavity of the scapula and the head of the humerus. It has the widest range of motion of any joint in our body. It's the classic ball and socket joint. But here's the trade-off. The wider the range of motion, the less stable the joint. Think about the socket itself. The glenoid cavity is actually quite shallow and flat, while the humeral head is a large round ball. Imagine putting a big ball on a small, shallow plate. It would roll right off, wouldn't it? So what holds it in place? That's the glenoid labrum. The labrum is a ring of cartilage that goes around the rim of the glenoid cavity, deepening the socket and holding the humeral head in. It's the key cartilage structure that maintains the stability of the shoulder joint. And this is why the labrum matters clinically. When the superior part of the labrum tears, we call it a slap lesion. This is common in athletes who repeatedly throw overhead. Baseball pitchers are the classic example. And when the anteroinferior part tears, we call it a Bankart lesion. This is the tear you see with recurrent or habitual shoulder dislocation. Once the shoulder pops out and the labrum is torn, it dislocates again and again more and more easily. So remember these two. Superior tear equals slap, anteroinferior tear equals Bankart. These will come up in your exams, and you'll see them constantly in orthopedic charts. Let's turn to the bones of the hand that fracture most easily. First, the distal end of the radius and ulna. This is Cole's fracture, one of the most common fractures we see, especially in older adults with osteoporosis who fall onto an outstretched hand. Second, the metacarpal bones, first through fifth. These often fracture from a direct blow, like punching something. Third, the scaphoid, one of the carpal bones. Scaphoid fractures are common in young people and athletes from a fall onto an outstretched hand, and they're notorious in clinical practice because the scaphoid has a poor blood supply. If missed on X-ray, it can lead to avascular necrosis, so it's a fracture we always need to keep in mind. Alright, now that we've finished studying the bones of the arm, it's time to move down to the leg. The leg is also divided into two main parts: the pelvic girdle, which connects the upper body to the lower body, and the bones of the lower limb. The pelvic girdle contains the large bone we call the pelvis. The pelvis is made up of three bones: the ilium, the ischium, and the pubis, fitted tightly together into a single mass, almost like a puzzle. Next, the bones of the lower limb. First, the femur, the longest and thickest bone in our entire body. The femur connects to the pelvis as a ball and socket joint, which allows for powerful rotational movement. Below that, we have the bones of the lower leg, the tibia and the fibula. The tibia and fibula are the leg's equivalent of the radius and ulna in the arm. Why do we have two bones, the radius and ulna, in the forearm? To make rotational movement of the hand easier. In the same way, the tibia and fibula provide stable support so the foot can rotate more easily as well. Now, we've been talking about the femur, the tibia, and the fibula. But there's one more round bone sitting between them, the patella, the kneecap, that sticks out right in front of the knee. For us humans who walk upright, the patella acts like a shield, protecting the knee joint and minimizing damage when we fall. Alright, now let's move down to the foot. The foot has 14 tarsal bones, the ankle bones. Because we walk upright, a lot of impact is transmitted to the foot, so these are extremely strong, dense bones that don't fracture easily despite all that stress. And finally, we have the metatarsal bones and the phalanges. Please make sure you memorize all the bone names I've gone over, including the spelling, letter by letter. Now, if you've memorized the bones of the leg, there's one joint in the leg that we absolutely have to know: the meniscus and the ACL and PCL. I've said walking upright a lot, and because of that, the impact on our knees is very frequent and very significant. If the knee takes a lot of impact, the bone would get damaged, right? What prevents that damage is the meniscus. It acts like a cushion. The meniscus can tear easily, or wear down and become damaged over time. In those cases, we perform an arthroscopic surgery to repair the meniscus. And then the ACL and PCL, these are the two axes that hold the knee stable and keep it from rotating. When your foot is planted on the ground and you suddenly pivot backward, the knee rotates, and the ACL or PCL can rupture. When that happens, gait stability is compromised, so we perform an ACL or PCL reconstruction surgery. Now, let's move on to the bones of the foot. First, the metatarsal bones, the first through fifth metatarsal bones. These fracture easily when a strong external force lands directly on the top of the foot. Second is Pott's fracture, involving the distal ends of the tibia and fibula. This is the most classic type of ankle fracture, involving a combination of a distal fibula fracture, a torn deltoid ligament, and a distal tibia fracture. Now, let's move on to the bones of the foot. First, the metatarsal bones, the first through fifth metatarsal bones. These fracture easily when a strong external force lands directly on the top of the foot. Second is Pott's fracture, involving the distal ends of the tibia and fibula. This is the most classic type of ankle fracture, involving a combination of a distal fibula fracture, a torn deltoid ligament, and a distal tibia fracture.